Let us embark upon a journey into the secret currents that sustain life, and sometimes, in their betrayal, extinguish it. This chapter tells the story of hemodynamic disorders, of clotting gone astray, of vessels burdened with blood, of tissues drowned in fluid, and of shock that pulls life towards its precipice. Sit back, for this tale is one of drama and consequence, where each beat of the heart may tip the balance between health and death. Introduction. The health of every living cell, of every tissue and organ in the human body, depends upon a single ceaseless miracle, the circulation of blood. It is blood that bears oxygen and nutrients to the periphery, and blood that gathers the waste of metabolism to be cast away. Under the delicate order of physiology, this flow is balanced. As blood passes through capillary beds, plasma proteins remain held within the confines of the vessels, and only a whisper of water and electrolytes moves outward into the tissues. But equilibrium is fragile. The slightest shift in the forces that govern this exchange may tip the balance. Endothelial dysfunction, heightened hydrostatic pressure, or the loss of plasma proteins, each of these can summon forth edema, that silent swelling, the accumulation of fluid within tissues. Sometimes it is trivial, no more than a puffiness in the ankles after a long day. Yet, in the lungs, where alveoli fill with fluid, the same process may turn fatal, silencing the breath itself. Equally dramatic is the compromise of the structural integrity of blood vessels. Trauma rends their walls, and the body responds with hemostasis, the choreography of clotting that staunches bleeding. But this system, so vital for survival, may falter. When inadequate, the price is hemorrhage, with shock and death looming close. When excessive, the clot grows where none is needed, obstructing the flow, birthing thrombosis and its dire offspring, embolism and infarction. Indeed, such thromboembolic disease claims the highest toll of human life in affluent nations, manifesting as myocardial infarction, pulmonary embolism, and stroke. And then there is the specter of shock, that final pathway of many catastrophes where circulation itself collapses, dragging the body towards irreversible failure. It is this panorama we shall traverse: edema and effusions, congestion and hyperemia, the mechanics of hemostasis and its betrayals in hemorrhage and thrombosis, the flight of emboli, the pale silence of infarction, and the dread descent into shock.
Edema and effusions. Now we step into the story of fluid, of its rightful home within vessels, and of its betrayal when it seeps into places it should not dwell. This betrayal is called edema when it appears in tissues, and effusion when it fills cavities. Both are the footprints of disrupted balance in the cardiovascular, renal, or hepatic systems. Under the serene order of health, two opposing forces stand face to face. On one side, vascular hydrostatic pressure pushes water and salts out of the capillaries. On the other, plasma-colloid osmotic pressure, drawn by proteins like albumin, pulls fluid back into the vessels. Normally, the two nearly cancel each other, so that only a trickle of fluid escapes into the interstitium, and even this is swept away by lymphatics, returning safely to the bloodstream through the thoracic duct. Tissues remain dry, and equilibrium reigns. But should hydrostatic pressure rise, or colloid osmotic pressure fall, the balance shatters. Fluid floods outward from the vessels, and when the lymphatics are overwhelmed, tissues swell. This swelling, silent and insidious, is edema. And when the serosal cavities, the pleura, the pericardium, or the peritoneum, are involved, the fluid collects as effusion. Edema and effusions come in two guises. When driven by inflammation, they are rich in protein, thick with the exudates of battle, the products of heightened vascular permeability and mediators of inflammation. When born of non-inflammatory causes, they are thin, poor in protein, and are called transudates. Such transudates accompany many chronic afflictions: the weary heart of failure, the cirrhotic liver, the failing kidney, the malnourished body. Each condition tips the balance, and water abandons the vessels. Let us now follow the trail of causes, one by one. Increased hydrostatic pressure. When the pressure within veins rises, water is driven out into the interstitial wilderness. This is the story of impaired venous return. If the block is local, as in a deep vein thrombosis snaring the limb, the edema is confined, swelling only the affected part. But if the entire circulation is burdened, as in congestive heart failure, then the edema spreads, general and unrelenting. Here, the heart, weakened in its pumping, allows venous pressure to rise, and the veins press their burden upon the tissues, reduced plasma osmotic pressure. Now consider the quiet pull of proteins in the plasma, especially albumin. It is albumin that holds fluid within vessels. Should it be lost, the pull weakens, and water escapes. Albumin may fail for two reasons: too little made, or too much lost. The failing liver of cirrhosis and the hollow stores of malnutrition cannot produce enough. The leaking kidneys of nephrotic syndrome spill albumin into the urine, their glomeruli too permeable to hold it back. Whatever the cause, the sequence is cruel but predictable: fluid seeps out, intravascular volume falls, renal perfusion dwindles, and the body, sensing loss, activates the renin-angiotensin-aldosterone system. Sodium and water are retained, but the underlying defect, the absence of protein, remains unhealed. Thus, the vicious circle tightens: more water, more edema, sodium and water retention. Next enters the role of salt. For wherever sodium goes, water must follow. Retention of sodium thus breeds both increased hydrostatic pressure and diluted plasma proteins. The kidney is at the center of this tale. Whenever renal function falters, whether through primary disease of its own or through diminished perfusion from heart failure, sodium accumulates. In the early whispers of heart failure, this retention is a friend, raising blood volume, shoring up perfusion, and maintaining cardiac output. But as the heart grows weaker, the friend turns traitor. Sodium and water pile up, hydrostatic pressures soar, and edema flourishes. Lymphatic obstruction. Yet even if the balance of hydrostatic and osmotic forces holds, edema may come if the lymphatic pathways, those secret rivers that drain away excess, are blocked. Trauma, fibrotic scars, invasive tumors, or parasites may choke the lymphatics. The result is lymphedema, a swelling firm and unyielding. Consider the grotesque tale of filarial infection. The worms, tiny architects of obstruction, weave fibrosis around lymphatic channels, and the swelling of limbs and genitalia grows monstrous, earning the name elephantiasis. Equally cruel is the swelling of the arm that may follow the removal of a breast and axillary lymph nodes in the treatment of cancer, or their destruction by radiation.
Clinical features of edema. The appearances of edema are many, from the trivial to the deadly. Subcutaneous edema may merely betray a deeper problem, pointing toward hidden cardiac or renal disease. Yet when severe, it hinders wound healing, slows infection clearance, and leaves its telltale sign: a thumb pressed against the skin leaves a hollow, a pit in the swollen sea of tissue. Renal edema has a special predilection: it chooses the soft tissues of the eyelids, giving rise to the characteristic puffiness of periorbital swelling. In the lungs, however, edema is merciless. The alveoli fill with fluid, gas exchange falters, oxygen falls, and the patient drowns in silence. Pulmonary edema often marches alongside pleural effusions, which further compress the lungs, worsening the suffocation. In the peritoneal cavity, the effusion called ascites gathers. Most often born of portal hypertension, it creates a stagnant pool where bacteria may thrive, leading to peritonitis, infection severe and sometimes fatal. In the brain, edema is perhaps most treacherous. The rigid skull gives no room for expansion. Swelling compresses gyri, narrows sulci, and in its extremity, may force the brain to herniate through the foramen magnum, strangling the medulla and extinguishing life. Morphology of edema. Seen with the naked eye, edema is swelling, soft and often glistening. Under the microscope, it reveals itself as the clearing of the extracellular matrix, a widening of the spaces between cells, and subtle swelling of the cells themselves. In the subcutaneous tissue, edema may be diffuse, or more pronounced in gravity-dependent regions, the ankles and legs in the standing, the sacrum in those lying down. This is the phenomenon of dependent edema. Press a finger, and the pit remains, the sign called pitting edema. In the lungs, the weight doubles or triples. On slicing, frothy, blood-tinged fluid pours forth, a mixture of air, plasma, and red cells. In the brain, swelling broadens the gyri and narrows the sulci, crowding the tissue within the unyielding cranial vault. Effusions too have their character. Transudates are pale, straw-colored, translucent. Exudates, rich in protein and cells, are cloudy, tinged with inflammation. Sometimes, lymphatic obstruction gives rise to a chylous effusion, milky and opaque, loaded with lipid absorbed from the gut. Key concepts: edema. Let us gather the essence. Edema is the escape of fluid from vessels into tissues or cavities. It may be transudate, poor in protein, or exudate, rich in it. Its causes are many. Increased hydrostatic pressure, as in heart failure. Reduced plasma proteins, as in liver disease, malnutrition, or nephrotic syndrome. Increased vascular permeability, as in inflammation. Lymphatic obstruction, as in infection or cancer. Sodium and water retention, as in renal disease. Edema is not merely a swelling, it is a signal, a symptom, a potential harbinger of death when it drowns lungs, presses on the brain, or invites infection into stagnant pools.
Hyperemia and congestion. Now we turn from the still waters of edema to the tides of blood itself. Hyperemia and congestion, two words that both signify an excess of blood within tissues, yet whisper very different stories of how that excess came to be. Hyperemia is an active rising tide. Arterioles dilate, and blood rushes into the tissue as if summoned by a call to arms. It is the flush of inflammation, the blush of exercise. Muscles in motion, skin inflamed by a wound, both glow with the vivid redness of oxygenated blood. This is hyperemia, a deliberate, orchestrated influx, bright with life. Congestion, by contrast, is a passive suffocation. It is the damming of venous outflow, the stagnation of blood unable to escape. In congestion, tissues darken with a dusky, cyanotic hue, the color of hemoglobin robbed of its oxygen, trapped within vessels that cannot empty. Congestion may be systemic, as in the failing pump of a weakened heart, or local, as in a limb strangled by a venous obstruction. In chronic congestion, the stasis of blood breeds chronic hypoxia. Cells hunger, tissues scar, and red cells that escape into the interstitium are broken down, their iron hearted by macrophages in telltale golden granules of hemosiderin. And often, congestion begets edema, for the pressure within veins presses fluid outward, adding swelling to suffocation. Morphology of congestion. The image of congestion is painted in shades of blue and red. To the naked eye, congested tissues appear swollen and dusky. Under the lens, blood fills capillaries, red cells stagnate, and vessels appear engorged. In the lungs, acute congestion reveals alveolar capillaries swollen with blood, septa thickened and heavy with edema, and here and there, the telltale stain of intraalveolar hemorrhage. As time marches into chronicity, fibrosis thickens septa, and macrophages swallow up escaped red cells, turning into heart failure cells heavy with hemosiderin, as though the very rust of blood has settled into their cytoplasm. In the liver, acute congestion distends central veins and sinusoids, starving the centrilobular hepatocytes of oxygen, and sometimes bringing necrosis. The periportal hepatocytes, closer to arterial inflow, may survive, bloated with fatty change but not dead. Chronic congestion paints a dramatic picture, the nutmeg liver. The centrilobular zones darken, red-brown and sunken with death, while the periportal regions remain paler, tan and viable. The cut surface resembles the marbled seed of nutmeg, beauty born of pathology. Microscopically, hemorrhage, congestion, and necrosis mark the centers. Hemosiderin-laden macrophages patrol the battlefield, and hepatocytes fall away. Thus congestion is more than a word. It is the suffocation of organs, the slow drowning of cells, a passive flood that leaves scars in its wake. Hemostasis, hemorrhagic disorders, and thrombosis. We now descend into the very theater of blood itself, where it must strike a balance between flowing freely and clotting instantly when danger arises. This balance is called hemostasis. Hemostasis is life's insurance against bleeding to death from the smallest cut. Yet it is also a dangerous ally, for when the balance tips, it can kill by clotting in the wrong place. Let us enter this finely tuned performance. When a vessel is injured, the very first act is arteriolar vasoconstriction. It comes swiftly, a reflex tightening that reduces blood loss in the first moments. This narrowing is driven by nerve reflexes and by molecules secreted locally, such as endothelin, the potent vasoconstrictor birthed from endothelial cells. But this effect is fleeting, for without the choreography of platelets and clotting factors, bleeding would resume unchecked. Then begins the formation of the platelet plug. The endothelium is breached, and the basement membrane is laid bare, revealing its von Willebrand factor and collagen. Platelets, those tiny, anucleate discs forever circling in the bloodstream, sense the exposure and cling to it, mediated by their glycoprotein receptors. In a heartbeat, they change form, spreading into spiny, sea urchin figures with vast surface area, releasing secretory granules rich in mediators. These messengers summon more platelets, which adhere in clump, building a fragile yet immediate barricade called the primary hemostatic plug. But the story does not end there. The vessel cries out a deeper alarm: secondary hemostasis. Tissue factor, normally hidden within subendothelial cells, now enters the stage. It binds to factor 7, and the cascade begins, a chain of enzymatic activations that converge upon thrombin, the great conductor. Thrombin cleaves fibrinogen into fibrin, laying down a mesh that cements the platelet plug, hardening it into a secondary hemostatic barricade. Thrombin also calls forth more platelets, amplifying the assembly. At last, the clot stabilizes. Fibrin and platelets contract, tightening into a firm wall that holds bleeding at bay. But nature, wise in its design, also whispers the command to restrain. Endothelial cells release tissue plasminogen activator, setting in motion fibrinolysis. Thrombomodulin bends thrombin's will, converting it from clot promoter to clot limiter. Thus, the clot is confined to the site of injury and later dissolved when healing is secure. This delicate equilibrium is the soul of hemostasis. Yet when it falters, two divergent tragedies arise. Too little hemostasis, and hemorrhage takes the stage, subtle bleeds, mucosal hemorrhages, menorrhagia, or catastrophic intracerebral rupture. Too much hemostasis, and thrombosis grips the body, clots forming where none should exist, lodging in vessels, choking life from tissues. It is here, in this knife-edge balance between bleeding and clotting, that much of human disease finds its drama.
The platelets. Picture the platelet, a mere fragment, a nucleate, derived from the mighty megakaryocyte in the marrow. It drifts silently in the blood, a disc-shaped sentinel, waiting for injury to summon it. Though mute and without nucleus, it is alive with receptors, with granules, with machinery primed for battle. When vascular injury strikes, the first act belongs to the platelet. It adheres to the exposed matrix, tethered by von Willebrand factor, which acts like a bridge between subendothelial collagen and the platelet's glycoprotein receptors. The once quiescent platelet awakens, undergoes a dramatic metamorphosis, extending pseudopods, spreading across the surface, and discharging its secretory granules. From the dense granules spill adenosine diphosphate and calcium, crucial mediators. From the alpha granules, clotting factors, fibrinogen, and growth factors are released. A wave of recruitment follows, neighboring platelets are activated, drawn into the growing mass, until the plug grows and stabilizes. Thromboxane A2, born of arachidonic acid metabolism, whispers the command for vasoconstriction and platelet aggregation, tightening the barricade. Thus, the platelet plug is formed, swift, improvised, fragile. It is the first line of defense, the wall raised within minutes of injury. Yet without reinforcement, it would crumble, and so the coagulation cascade enters. The coagulation cascade. Now comes the more intricate dance, the chain of enzymes, each activating the next, culminating in the mighty thrombin. The cascade was once divided into intrinsic and extrinsic pathways, names born of laboratory tests. Yet in truth, in the living body, it is the extrinsic pathway, initiated by tissue factor, that reigns supreme. Tissue factor, released by injured endothelium and subendothelial cells, binds factor 7, awakening the chain. Thrombin is the climax of this story. It is not merely an enzyme, it is a master of ceremonies. With a flick of its proteolytic blade, it cleaves fibrinogen into fibrin monomers, which polymerize into insoluble strands. These strands weave around the platelet plug, transforming it into a fortress of fibrin and cells. But thrombin's power extends far beyond fibrin. It amplifies the cascade by activating factors V, 8, and 11, ensuring that once begun, the storm accelerates. It rouses platelets further, calling them to aggregate and to secrete more mediators. It even influences leukocytes and endothelium, linking hemostasis with inflammation and repair. In laboratory halls, the coagulation cascade reveals itself through two great assays. The prothrombin time, or PT, measures the extrinsic pathway, sensitive to factors 7, X, V, prothrombin, and fibrinogen. The activated partial thromboplastin time, or APTT, reflects the intrinsic pathway, dependent on factors 12, 11, X, 8, as well as common components. These assays, though born of test tubes, illuminate the functioning of the cascade in health and in bleeding disorders. Yet clotting unchecked would be a curse. And so nature binds the cascade with inhibitors, antithrombin, which neutralizes thrombin and factors IXA and ZA, protein C and protein S, which silence factors VA and VIA. These sentinels guard against runaway coagulation, preserving balance. The endothelium. At the heart of this drama stands the endothelium, the thin layer of cells that lines every vessel, both shield and signaler. Endothelium is Janus-faced. In health, it resists clotting; in injury, it promotes it. In its resting guise, endothelium is profoundly anticoagulant. It secretes nitric oxide and prostacyclin, vasodilators that prevent platelet adhesion. It displays heparin-like molecules that enhance antithrombin activity. It presents thrombomodulin, which converts thrombin from a clotting enzyme into an activator of protein C, thereby curbing further clotting. It also releases tissue plasminogen activator, the key that unlocks fibrinolysis, ensuring that clots dissolve once their work is done. But when injury or inflammation disturbs it, the endothelium changes its mask. It expresses tissue factor, igniting the cascade. It secretes von Willebrand factor, promoting platelet adhesion. It binds activated platelets and clotting factors, turning from a guardian into a conspirator in thrombosis. Thus, the endothelium is no passive lining but an active participant, a regulator of hemostasis, capable of tilting the scales toward bleeding or clotting, life or death. Primary and secondary hemostatic disorders. Now, let us pause to observe how this machinery may falter. If platelets are too few, as in thrombocytopenia, or too ineffective, as in inherited disorders, then primary hemostasis fails. The signs are immediate and superficial: petechia, tiny pinpoint hemorrhages upon the skin, purpura, larger patches, and mucosal bleeding from gums, nose, or gastrointestinal tract. When the coagulation cascade falters, however, the hemorrhages are deeper and more insidious. Hemarthroses swell the joints, muscles bleed, and post-surgical wounds ooze unstoppably. These are the marks of secondary hemostatic disorders. Both realms of failure converge in their danger: unchecked bleeding, shock, and death. Hemorrhage. Hemorrhage itself is the ultimate manifestation of failed hemostasis or breached vessels. Blood escapes its confines, flooding into tissues, cavities, or outward into the world. Tiny capillaries may leak, producing petechia, or slightly larger purpura. More substantial bleeds, called ecchymoses, paint the skin in patches of purple and blue, slowly fading through the hues of green and yellow as hemoglobin breaks down into biliverdin and bilirubin. When blood accumulates within tissues in mass, it forms a hematoma, ranging from trivial to fatal. In the brain, a hemorrhage of even a few milliliters may extinguish consciousness and life itself. Blood lost externally may be measured, but internally it may remain hidden until anemia or shock unveils it. Loss of more than 20% of blood volume is perilous, but the rate of loss determines the body's fate. A slow trickle allows adaptation, a sudden torrent overwhelms. Hemorrhage may be inherited, as in deficiencies of clotting factors, or acquired, as in trauma, vitamin K deficiency, or therapy with anticoagulants. Whatever the cause, it reminds us that the circulatory system is not invincible, it is fragile, ever vulnerable to rupture.
Thrombosis. Thrombosis is hemostasis turned against its master. What should have been a fleeting, localized plague to save life at the site of injury, becomes instead an unwanted and often fatal obstruction in the living channels of blood. A thrombus is nothing more than a clot, but its birthplace is what makes it deadly. Unlike the clot that seals a wound, a thrombus forms within intact vessels or within the heart, uncalled, unneeded, and treacherous. The genesis of thrombosis was first captured by the mind of Rudolf Virchow in the 19th century, and his triad remains a cornerstone of pathology. 3 conditions open the gates to thrombosis: endothelial injury, stasis or turbulence of blood flow, and hypercoagulability of blood. Endothelial injury. Foremost among the causes is injury to the endothelium. When the smooth, anticoagulant lining of the vessel is breached, the hemostatic machinery awakens. Consider the atherosclerotic plaque, ulcerated. It exposes subendothelial collagen, releasing tissue factor, drawing platelets like moths to a flame. In myocardial infarction, endocardial injury stirs mural thrombosis. In vasculitis, inflammation scars the endothelial surface. In each case, injury converts the vessel wall from a guardian of fluidity into an instigator of clotting. Abnormal blood flow. But injury alone does not tell the whole tale. Even without overt damage, abnormal blood flow conspires to favor thrombosis. Normally, blood races forward in laminar streams, the platelets and cells coursing through the center, while the plasma skims along the vessel wall, washing it in an anticoagulant film. Yet when flow becomes turbulent, as it does at arterial bifurcations or across an atherosclerotic plaque, the protective separation collapses. Platelets are flung against the endothelium, clotting factors mix chaotically, and natural inhibitors are swept away. In stasis, as in dilated atria of fibrillating hearts or in veins immobilized by bed rest, the result is equally dire. Fresh clotting factors accumulate, natural anticoagulants are not replenished, and hypoxia injures endothelium. Stasis is the silent ally of thrombosis, particularly in the veins of the legs, where deep venous thromboses are born. Hypercoagulability. The third arm of Virchow's triad is hypercoagulability, a state where the blood itself is more prone to clot. It may be inherited or acquired. Among inherited causes, the most common is the mutation in factor V, called factor V Leiden. This mutant form resists degradation by activated protein C, allowing clotting to proceed unchecked. Prothrombin mutations, 2, elevate thrombotic risk by raising prothrombin levels. Deficiencies of antithrombin II, protein C, or protein S remove critical brakes on coagulation. Acquired causes abound. The most notorious is the antiphospholipid antibody syndrome, in which autoimmune antibodies bind to phospholipid protein complexes, both prolonging clotting times in vitro yet causing thrombosis in vivo. Cancer is another great driver, tumors releasing procoagulant products that tip the balance. And in many patients, surgery, trauma, pregnancy, and immobility all stoke the blood toward clotting. Thus, endothelial injury, abnormal flow, and hypercoagulability form a trinity of doom, converging to create thrombosis. Morphology of thrombi. What, then, does a thrombus look like? In arteries or cardiac chambers, thrombi cling tightly to the wall. They are firm, gray, and friable, with the telltale lines of xanth, pale layers of platelets and fibrin alternating with darker layers rich in red cells. These striations reveal that the clot formed in flowing blood, not in stagnant postmortem stillness. In veins, thrombi are softer, more enmeshed with red cells, forming what are often called red or stasis thrombi. They mold themselves to the vessel, sometimes filling it entirely in a long cast. Microscopically, both arterial and venous thrombi show a dense web of fibrin, platelets, and trap cells. With time, they may undergo organization, ingrowth of fibroblasts and capillaries, and in rare cases, recanalization, where new vascular channels pierce through, reopening flow. Fate of thrombi. The destiny of a thrombus lies on four roads. It may propagate, enlarging further, enlisting more platelets and fibrin. It may embolize, breaking loose and traveling as a lethal wanderer to distant sites. It may dissolve, especially if fresh and attacked by fibrinolytic activity, leaving no trace. Or it may organize and recanalize, being woven into the vessel wall, and partly restored to function. But too often, propagation and embolization are the chosen paths, and these lead to death. Clinical consequences. The consequences of thrombosis depend on its site. Arterial thrombi are most often superimposed upon atherosclerotic plaques, and they are the culprits behind myocardial infarction, cerebral infarction, and gangrene of the extremities. Venous thrombi, especially those of the deep veins of the legs, are more insidious. They may be silent, unnoticed until they cast forth an embolus into the lungs, where sudden death awaits. Thrombosis is therefore not only a pathological curiosity, it is a leading actor in the theater of human mortality, its hand behind the commonest killers in the developed world.
Embolism. An embolus is a traveler, a fragment set loose within the bloodstream, carried by the flow, until it lodges in a vessel too small to pass. Most emboli are born of thrombi, and when they are, we call them thromboemboli. Yet the story is broader. Fat droplets, nitrogen bubbles, amniotic fluid, fragments of atherosclerotic debris, even tumor cells may become emboli. Whatever their origin, their consequence is the same: they obstruct flow, starve tissues, and summon infarction. Pulmonary thromboembolism. Nowhere is the drama more vivid than in the lungs, the great filter through which the venous blood of the body must pass. Pulmonary embolism is common, deadly, and often silent until catastrophe strikes. Most pulmonary emboli arise from deep venous thrombosis of the legs. A fragment breaks loose, enters the right side of the heart, and from there, is pumped into the pulmonary arteries. The fate of the embolus depends on its size. If massive, it may block the main pulmonary artery or its branches, halting circulation, straining the right ventricle, and causing sudden death, sometimes before the diagnosis is even suspected. Smaller emboli wedge into peripheral arteries, cutting off blood supply to lung segments. The dual circulation of the lung, with both pulmonary and bronchial arteries, usually protects against frank infarction. Yet if bronchial flow is compromised or the heart is weak, pulmonary infarcts occur, often hemorrhagic, wedge-shaped, and painful, as the pleura becomes involved. Most emboli are multiple, showering the lungs in recurrent assaults. Repeated small emboli may be clinically silent, yet add up to pulmonary hypertension and right heart strain. The paradox of pulmonary embolism is that it may be both silent and sudden, trivial or fatal, a specter haunting every bedridden patient with deep venous thrombosis. Systemic thromboembolism. Emboli may also course through the arterial tree, arising not from veins, but from the heart or aorta. These are systemic thromboemboli, and they strike wherever arteries carry them. Most originate within the left heart mural thrombi upon infarcted endocardium or atrial thrombi, in the quivering chambers of atrial fibrillation. A smaller share arise from ulcerated atherosclerotic plaques or from aneurysmal dilatations of large arteries. Once loosed, they may lodge in any artery. The brain is their favored destination, and cerebral infarction is the frequent and devastating result. The kidneys, spleen, intestines, and lower limbs are also frequent victims. The consequences depend upon the tissue's vulnerability to ischemia and the size of the vessel occluded, but the end is almost always the same: infarction, necrosis of tissue, and loss of function. Fat and marrow embolism. Not all emboli are clot. In the aftermath of severe skeletal trauma, especially fractures of long bones, droplets of fat and marrow elements may enter torn venous sinusoids and be carried to the lungs. This is fat embolism, often clinically silent, but in some, giving rise to the fat embolism syndrome. This syndrome emerges a day or two after injury, with sudden respiratory difficulty, neurologic disturbances like confusion or seizures, and the curious appearance of petechial rash. The lungs fill with edema and hemorrhage, the brain suffers ischemia, and death may follow. Microscopically, fat globules are seen in the vessels, sometimes encrusted with platelets and fibrin. It is a cruel complication of trauma, one more peril faced by the wounded. Air embolism. Even air, if it enters the circulation in volume, may become embolic. A small amount, as from injection or minor surgery, is absorbed without harm. But when liters of air are introduced, as in trauma to the chest wall or during obstetric mishaps, the froth may block blood flow in the heart and lungs. In divers who rise too quickly from the depths, nitrogen dissolved at high pressure comes out of solution, forming bubbles in blood and tissues. This is decompression sickness. Joints ache, a torment called the bends, and the lungs may seize in choking distress, the chokes. In severe cases, bubbles lodge in the brain, spinal cord, and heart, causing ischemia and death. Chronic exposure, as in workers of caissons and tunnels, may leave behind ischemic necrosis of bone, a legacy of a vascular necrosis, in the heads of femur, tibia, or humerus. Amniotic fluid embolism. Perhaps the most dramatic and feared embolus is that of amniotic fluid. Rare though it is when it strikes, it is catastrophic. During labor or in the postpartum period, tears and placental membranes or uterine veins may allow amniotic fluid and its debris, fetal squamous cells, lanugo hair, mucin to enter the maternal circulation. The result is sudden collapse. The mother gasps for air, falls into shock, and often convulses. Disseminated intravascular coagulation is triggered, for the amniotic contents are rich in tissue factor. Bleeding, cyanosis, and coma follow in rapid succession. Histologically, pulmonary vessels are filled with fetal cells and debris, a chilling testimony to the cause. Though rare, this is one of obstetrics' most feared catastrophes. The essence of embolism. Thus the embolus, whether clot, fat, air, or amniotic fluid, is always a wanderer-bearing death. It travels silently until it reaches a vessel too small, where it arrests flow, and the tissue beyond starves. It is a cruel lottery, striking suddenly, choosing organs at random, and often leaving devastation in its wake. Infarction. An infarct is death stamped upon tissue by the cessation of its blood supply. It is necrosis born not of infection or trauma, but of ischemia, the simple, brutal deprivation of oxygen and nutrients. The occlusion may be arterial, denying inflow, or venous, blocking outflow, but the result is the same. A zone of necrosis, pale or hemorrhagic, silent or screaming, yet always irrevocable. The causes are legion, yet most often the assassin is a thrombotic or embolic event. In the heart and brain, arterial thrombosis upon atherosclerotic plaques is the great culprit. In the lungs, emboli shower from venous thrombosis. In the intestines, the mesenteric vessels may be strangled. Venous obstruction, less common, produces congestion so severe that arterial inflow fails, leaving organs such as the testis or ovary infarcted after torsion. Morphologic types of infarcts. Infarcts are painted in two main hues, white and red, pale and hemorrhagic. White infarcts are born of arterial occlusion in solid organs with end arterial circulation, such as the heart, spleen, and kidney. With no room for collateral flow, the tissue becomes pale, wedge-shaped, with its base upon the organ surface and its apex pointing to the occluded vessel. Microscopically, coagulative necrosis reigns, with preservation of outlines but loss of nuclei, and eventually infiltration by inflammatory cells and scar formation. Red infarcts, by contrast, occur in settings where blood suffuses the dying tissue. This happens in venous occlusions, as in torsion of the ovary. It happens in tissues with loose architecture, such as the lung, where blood can seep in from bronchial circulation. It happens when occlusion occurs in a previously congested organ, or when blood flow returns to an area of necrosis, hemorrhaging into its frail vessels. These infarcts are hemorrhagic, dark red, often wedge-shaped, and histologically show coagulative necrosis overlain by extravasated red cells. The brain stands apart, for cerebral infarcts do not undergo coagulative necrosis, but liquefactive necrosis. The tissue softens, digests, and is replaced by a cystic cavity. Factors influencing infarction. Whether an occlusion culminates in infarction depends on several factors. The anatomy of the blood supply is paramount. Organs with dual or rich collateral circulation, the lungs, liver, hand, forearm, are more resistant. By contrast, end arterial organs like the kidney, spleen, and heart are fragile, their tissues easily silenced by a single block. The rate of occlusion also matters. A slow narrowing allows collaterals to develop, whereas a sudden embolus brooks no adaptation. The vulnerability of the tissue plays its role too. Neurons perish within minutes of ischemia, myocardial cells within half an hour, but fibroblasts may endure for hours. And systemic conditions, such as anemia or hypoxemia, amplify the risk, for if the blood is poor in oxygen, even partial reductions in flow may prove fatal. Clinical consequences. Infarcts are clinical turning points, moments of great consequence. Myocardial infarction is the prime killer, the necrosis of heart muscle, leaving scars that never contract again. Cerebral infarction brings stroke, paralysis, and loss of speech. Pulmonary infarction causes pain, hemoptysis, and breathlessness. Intestinal infarction is one of the most agonizing events in medicine, with gangrene of bowel and rapid death if not reversed. Thus, infarction is the footprint of obstructed flow, the endgame of thrombosis and embolism, the final common pathway of vascular catastrophe. Shock. Shock is the great undoing of the circulatory system. It is not a disease of a single organ, but the failure of the whole body's perfusion, leaving tissues undernourished, hypoxic, and dying. The word itself conveys terror: a sudden blow, a collapse, a stunned silence of the organism. In medicine, shock is the final common pathway of countless insults, from blood loss to sepsis, from trauma to anaphylaxis. Whatever the cause, the essence is the same. The heart and vessels fail to deliver oxygen to tissues, metabolism falters, and organs fall one by one. Types of shock. Though the final outcome is unified, the entryways into shock are many. Cardiogenic shock arises when the heart, the pump itself, fails. Myocardial infarction, arrhythmia, cardiac tamponade, pulmonary embolism all can silence the pump, leaving blood stagnant within chambers that should drive it forward. Hypovolemic shock comes from loss of volume, the emptying of the vascular tree. Hemorrhage, severe burns, or dehydration strip the system of fluid, leaving the heart with nothing to propel. Shock associated with systemic inflammation is a more insidious form. It occurs in sepsis, the overwhelming response to infection, or in anaphylaxis, the violent allergic storm. It occurs in severe trauma, burns, or pancreatitis. Here, inflammatory mediators flood the system, inducing vasodilation, increased vascular permeability, and pooling of blood away from the core. Though volume remains, it is misplaced, leaking into tissues or trapped in dilated beds, starving vital organs. Septic shock deserves special mention, for it is among the most common and lethal. It is not the bacteria themselves that kill, but the host's furious, dysregulated response. Endotoxins, cytokines, complement, and coagulation pathways all conspire, producing vasodilation, endothelial injury, disseminated intravascular coagulation, and metabolic derangements. It is a storm within the vessels, a collapse born of excess immune zeal. Pathogenesis of shock. Despite their varied causes, all shocks converge on the same outcome: inadequate tissue perfusion. This perfusion crisis is compounded by cellular responses. Hypoxia drives cells to anaerobic metabolism, lactic acid accumulates, and acidosis impairs enzymatic function. Sodium and water flood into cells, while potassium leaks out. Mitochondria fail, membranes rupture, and cells die. It is a spiral of injury, once begun, hard to arrest. Stages of shock. Shock is not instantaneous death. It is a progression, a grim march through stages. The initial non-progressive stage is the stage of compensation. The body detects the fall in perfusion and fights back. Baroreceptors trigger tachycardia and vasoconstriction. The renin-angiotensin axis conserves fluid. Blood is shunted from skin to heart and brain. Clinically, the patient is pale, clammy, with a rapid pulse, but still conscious and salvageable. If the insult continues, the progressive stage sets in. Here, compensation fails. Tissue hypoperfusion worsens, lactic acidosis deepens, vasodilation overtakes vasoconstriction, and blood pools. The patient becomes confused, urine output falls, and organs begin to falter. Finally comes the irreversible stage. The injury is now too great to reverse, even if perfusion is restored. Cells are dead, lysosomal enzymes leak, myocardium is stunned. The intestine is permeable to bacteria, and multi-organ failure cascades into death. Morphology of shock. Though shock is systemic, its footprints can be found in tissues. In the brain, ischemic encephalopathy appears, neurons shrunken and dying. In the heart, contraction band necrosis may appear. In the kidneys, the tubules suffer acute injury, giving rise to oliguria and sometimes renal failure. The lungs in septic shock may develop diffuse alveolar damage, the clinical picture of acute respiratory distress syndrome. The adrenal cortex may be hemorrhagic, the gastrointestinal mucosa may ulcerate, and disseminated intravascular coagulation may lace the body in microthrombi. Shock is not just physiology. It leaves scars in every organ. Clinical consequences. The outcome of shock depends on its cause, severity, and the swiftness of intervention. Young and otherwise healthy patients may survive even profound insults if rapid resuscitation is given, but the mortality of septic and cardiogenic shock remains high, despite modern therapies. The key to survival lies in recognition and reversal before the spiral reaches irreversibility. Once tissues have crossed into the chasm of necrosis and multi-organ failure, medicine's hands are tied. The final reflection. Thus ends the tale of hemodynamic disorders, thromboembolic disease, and shock. From the quiet swelling of edema to the drowning congestion of veins, from the platelets rushing to a wound to the thrombus betraying its master, from the wandering embolus to the silent infarct, and at last to the collapse of circulation in shock, we have walked the whole arc. It is a tale of balance and imbalance, of systems designed for life, yet so easily tipped into death. The chapter reminds us that blood is not only the river of life, but also the river that, when obstructed or poisoned, can carry us swiftly to our end.